We are live now, Doctor.
Okay, thank you very much. Good evening to all of you. Let me welcome all of you here for this Rajan Eye Care, Rajan Eye Ophthalmic Education Series, which is called the RIOS webinar. This is episode 11. And this episode, we are going to cover a very important topic called Pachychoroid spectrum. We have had several webinars, and all the webinars have been a runaway success. Webinars on cornea, oculoplasty, pediatric ophthalmology, retina, cataract, and all other specialties as well, subspecialties as well. All the webinars have been well received by the ophthalmologists and practicing, practicing ophthalmologists and the residents as well. And this webinar is also live on the YouTube and the Facebook. We have excellent speakers today and also the galaxy of faculty who are all experts in retina. Let me introduce first the speaker. The speaker is none other than Dr. Parveen Sain, who doesn't require any introduction. She's an authority on retina and she heads the Department of Vitreoretinal Surgery in Shankar Nethralaya. Parveen has done several publications, done a lot of work which is related to the pachychoroid spectrum. And it's a pleasure to have Parveen here with us, and she'll be giving a talk for about 30-35 minutes on the pachychoroid spectrum. Along with Parveen, we have the panelists. We have Dr. Ajay Arora from Noida, who's a top retina guy in Delhi and Noida, and he's got his own private practice, a very good friend of mine, and he's also a very innovative guy. He's got a lot of jugaads as far as the retina surgery is concerned. And we had a live surgery in the surgical strikes by Ajay Arora also this year. And we also have Dr. Karthik Srinivasan from Aravinda Hospital, Chennai, who's a upcoming dynamic, young vitreoretinal surgeon. We saw his fantastic macular hole surgery in the surgical strikes last year. We also have Dr. Manoj Khatri of Rajan Eye Care and Eye Docs, who is a very, very dynamic and very prolific vitreoretinal surgeon. And it's a pleasure to have Manoj Khatri here with us. And of course, Supriya Gautam of Rajan Eye Care again, who heads the vitreoretinal department, who does a lot of work on the pachychoroid spectrum as well. I'm the moderator, Dr. Mohan Rajan of Rajan Eye Care, and I'll be moderating the session. The sequence of the whole session is like this. Dr. Parveen will give a talk for about 35 minutes, 30 to 40 minutes. And then we have a small talk by Ajay Arora. He's going to share his slides as well for about 5 minutes or so on his experience with pachychoroid spectrum. As you all know, pachychoroid spectrum is a new entity. It's a new concept. There are areas of dark areas or gray areas as far as CSR, IPCV, everything is concerned. And all these has been grouped under pachychoroid spectrum. And we're going to talk about PPE, not the PPE of the COVID, but the PPE of the pachychoroid spectrum, the pachychoroid pigment epitheliopathy. For all this, we have Dr. Parveen Sain to unfold the mysteries behind this pachychoroid spectrum. Over to Dr. Parveen.
Thank you, Dr. Mohan Rajan, and I must thank Dr. Mohan Rajan and Manoj for organizing this webinar. It's the 11th in the series of their webinars on education. I must congratulate the Rajan Eye Care team for continuing the education series during these times. So it helps stimulating the students as well as the ophthalmologists while they have difficult times to face. So with this, without wasting any more time, I'll take you towards the whole spectrum of pachychoroid diseases. And as Dr. Rajan mentioned, that we are going to discuss various aspects like CSC, PPE. So we'll go towards them one by one. So to begin at the beginning and to begin at the basics, pachychoroid. So it is an abnormally thickened choroid as seen on OCT. And so what is normal choroid? So normal, anything between 200 to 350 would be something like a normal choroidal thickness. And something more than that, uh, 300 or even up to 400 micron will be considered.
Parveen, can you be a little louder?
Sure.
Thanks, thanks.
So we are looking at absolute thickness, and then so this is something, if you can see the slides, this is large choroid and it is present all around. So this is pachychoroid and it may be diffuse, or as you see in this one, it is focal. So the surrounding choroid looks normal, but under the area of pathology, there is a large choroidal vessel here. So this is a focal kind of a pachychoroid. So how does a pachy vessel differ from a normal vessel? Normally, the choroidal vessel, they either taper or disappear when they go towards the fovea or the macula. But the pachy vessels, they do not disappear. You can see these large vessels, they remain like that and there is no tapering. They remain uniform and dilated throughout the caliber of the vessel. And on ICGA, these are seen as dilated vessels, or in the early phase of the ICG, you may see it as a choroidal filling defect. And in the late phases, it may leak. And on OCT, these will be seen as dilated choroidal vessels. And you must understand, if you remember from the anatomy, we have 5 layers of choroid. The outer lamina, followed by the we have the hallux layer, the sacculus layer, the choroid, choriocapillaris, and the Brooks membrane. So it is not that all the layers of choroid are dilated. It is largely the outer hallux layer which gets dilated, and this causes compression of the sacculus layer and choriocapillaris. Choriocapillaris is the one which is responsible largely for the nourishment of the retina. So once it gets compressed, it gets thinned out, the nourishment of the retina is compromised, there is ischemia, and this leads on to secondary changes in the retina as well. So we have pachyvessel. To just make sure that I clear this one point, you may have dilated vessels which are seen on OCT. They may not all be may not all show hyperpermeability, but all hyperpermeability vessels will be dilated, but not all dilated vessels will be hyperpermeable. So this again, to clarify the point which I said, this is something like a normal choroid that you can see. And here you can see there is thickening of the outer vessels and the inner stromal layer of the choriocapillaris that is thinned out. So these are the selective changes which have to be appreciated. In fact, the selective changes may be different in PPE, in PNV or CSC. This is how you calculate the CVI also. And this gives you a ratio between the luminal and the stromal area of the choroid. So essentially, dilatation of the hallux layer, compression of the choriocapillaris, and alteration of the RP and thinning of the outer nuclear layer of the retina is what is called pachychoroid disease. So you can have uncomplicated pachychoroid in which the retina is not yet affected. You can have the PPE where only the retinal pigment epithelial changes are seen, otherwise everything else is normal. Then CSC, PNV, PCV, focal choroidal excavation, peripapillary pachychoroid syndrome, and pachydrusen. We'll quickly go through each one of them. This, as I said, there is only dilatation of the choroidal outer vessels, but the inner retina looks normal, RP is normal. So this is uncomplicated pachychoroid. The next one is, these are the next ones which we'll talk about. In fact, there's recently one article which has come on pachychoroid geographical atrophy also. But since there are hardly one or two articles on it, I will not touch upon it in detail. Do not want to confuse with too many terms. So first going to CSE. So we all know that this is the hallmark of the disease is neurosensory detachment, and the role of steroids is well known. Typical acute CSR presents with a smokestack pattern, a pigment epithelial detachment, or an ink blot seen leak. And if you see the OCT, this is the pigment epithelial detachment. Beautifully, it shows you the neurosensory detachment, and it shows you the large choroidal vessel. Treatment to this small ink blot sign is all that is required. Dr. Ajay would love to do just yellow laser here. And this is what you get, a flattened out retina, and that's the end. But it doesn't always end as happily as this. The acute CSC picture lasts for less than 6 months, but once you have it staying on for more than 6 months in different episodes of activity, you have more disturbance in the RPE, you have formation of these areas where this SRF has been present. This gives rise to the gravitational tracts, and this is how it appears on FAF. You can see these granular hypo and hyper autofluorescent areas on FAF, while the ICG early phase may shows very little choroidal hyperpermeability. In the mid phase, it starts showing much more. You can see the dilated pachy vessels here. They are dilated here, and this is the area of abnormality. And FFA in chronic phases may only show you stippled hyperfluorescence. It may not show you the classic ink blot or the smokestack pattern. The ICGA mid phase is going to show you dilated vessels, the pachy vessels here. And then you have on the later stages, this is typical of the chronic CSC. Again, another example of chronic CSC, you have a leak here along with hyperfluorescence on ICG. And CSC in ICGA is very useful in CSC because it picks up the early choroidal filling delay, the large choroidal venous dilatation, and the hyperfluorescence. And you can see even cases of multifocal CSC which present with multiple areas of hyperfluorescence as seen on ICG as well as FFA. This is how OCT looks like in chronic CSC. You have cystoid macular edema, which is a little less known fact of CSC. You have these shaggy, elongated photoreceptors because of reduced apoptosis. Then you have subretinal fibrin, then subretinal precipitates. Okay, and another thing which has become a focus of um, most of the recent discussions on CAC is a flat irregular PED, or what we call FIPED. So you can see this is chronic CSC and the RPE gets elevated here, almost like a double layer sign. Here again, you see a small double layer sign, a small flat PED here, and the same thing present here. So very similar picture in all 4 OCTs, but each one will show something different, and all of them have this dilated choroidal vessel. So just to show you some example, this was a 53-year-old male who I saw in my clinic, and he was diagnosed elsewhere to have chronic CSC and actually was sent with the referral letter for PDT. And we did the FFA ICG, which showed hyperpermeability. But the amazing thing was on OCT. When I saw the OCT, there was typical dilated choroid, but there was this elevated double layer sign which was present, which with my experience of PCV, I always thought that double layer sign meant there was an underlying BVN. And we did have access to OCTA at this time. And you see a beautiful network is sitting here. So this was a case of neovascular CSC, and I changed the treatment from PDT to intravitreal anti-VEGF. Though anti-VEGFs are not known to have great effect in CSC, but in presence of neovascular type 1 CNV, anti-VEGF becomes the treatment of choice, which is why it is very important to diagnose this. With a single injection, the FIPED goes away, is probably still there, but the fluid goes away, the choroidal thickening is still there. And even 1 year down the line, he does well, there is no recurrence seen. Another example of a 34-year-old male, you can see there is a smokestack here, there is choroidal hyperpermeability on ICG, but when I do the OCT, there is a hint of a DLS. So with my previous experience now, the moment I see a DLS, I always ask for an octa. So the octa here showed me the hypospace corresponding to the SRF, which is present here, but there was no CNV seen in any of the segmentation slabs. Another example, large choroid, DLS, minimal fluid. Of course, these are chronic changes of CSC, almost a plaque-like appearance on ICG. So definitely Octa was necessary, but Octa did not show me a neovascular network, and we went ahead with PDT instead. Another example, this is CME. So the patient had to undergo cataract surgery, and we thought it's probably a DME because he was a diabetic also. So we were thinking whether we should combine. Having done Octa, I saw a neovascular network. So it showed me that it was actually chronic CSC with the type 1 CNV. So instead of steroid, we gave anti-VEGF along with cataract surgery. So you can see that this is a role which Octa which is doing here, and almost none of the cases has Octa missed the this type 1 CNV, which can be seen chronic CSC. So not all fipids have this. Hyperreflective fipids are generally avascular. Hyperreflective fipids, again, to compound your problem, do not always have a type 1 CNV. So you need to have Octa to rule out the presence of a CNV. And usually these CNV are quite large and well organized vascular network is seen. More the height and width of a fipid, more the chance of it to be a CNV there. So this is a change in practice pattern which we have been following till now. So once you see a chronic CSC, you do an octa, divide it into a neovascular CSC or a non-neovascular CSC, because the treatment outcome and your visual prognosis is going to change, where anti-VEGF is a treatment of choice for neovascular. And generally, the visual prognosis is poor initially, but and final visual acuity may also be poor because of the presence of a CNV there. Limitations are that sometimes the CNV may not be the only reason why fluid is there, because if you remember, there is choroidal hyperpermeability also. So sometimes if you just treat the CNV, the fluid may still not go away, and the vice versa is also true. Sometimes you may not have fluid, you may have a present CNV. So
Right, Lava.
so from there, we go to the next one, which is the pachychoroid pigment epitheliopathy. So this shows mottling of the RP, absence of soft juice. Here, the only thing is important. There is pachychoroid, and then there are few focal RP disturbances above the pachychoroid, which shows you that it is a pigment epitheliopathy. You may have RP elevation with a micro break appearance or a small PED or a hyperreflective RPE. So generally reduced fundus tessellations in association with pigment epithelial changes because of the underlying choroidal hyperdilatation is what PPE is all about. And usually this is the form of reste of CSC, and patients end up developing CSC later. Pachydrausin, again, drusen seen in the setting of large choroidal vessels is pachydrausin. Usually these are large and the size is usually more than 125 micron, and patient is asymptomatic. They are usually present near the arcades, may not always be subfoveal, they're scattered, and this is what has been defined. A large drusen more than 125 micron in the setting of a large dilated choroidal vessel is pachydrausin. Pachychoroid neovasculopathy, we all were we understood it as a type 1 CNV in presence of a dilated choroidal vessel. So now with the presence of neovascularization also in vascular CSC, one starts thinking, how does this differ from a pachychoroid neovasculopathy? So, important thing to remember is PNV will not show you any of the gravitational tracts or the other signs of chronic CSC which may be present in cases of a vascular CSC. So, only type 1 CNV with dilated choroid is PNV. Type 1 CNV with dilated choroid with other changes of chronic CSCR is vascular CSC. Treatment for both these entities is an anti-VEGF. Fewer injections are usually required and longer treatment-free interval may be there vis-a-vis AMD. This is an example to show you how it looks like. So the sub-RP space is hyper-reflective and the chances of your seeing a CNV is definitely there, and you see a well-defined network which is seen on Octa. So the PCV, we are all much more familiar with, and we know that it has a wide range of spectrum, first defined by Januzzi. And the typical characteristics are that it has two aspects. One is a BVN and the other is a polyp. And you can see both of them very nicely here. This is a large BVN which is present, and these are the polyps, which are seen very nicely in ICG. And it is very important to look at the ICG in early frames of the disease. The diagnostic criteria for polyp is within the first 6 minutes of ICG. In fact, within the first 1 minute of ICG, you can recognize a BVN, which is seen here, or maybe if you want to see the feeder vessel, usually the first 1 minute itself. And in the first 6 minutes, you should be able to pick up the polyps, which are typically hyperfluorescent with the hypofluorescent halo around them. And pulsatile polyps, if you are looking at a video ICGA, is typical of PCV. This is something which is very less described, but it is very typically seen at about 10 minutes and after the injection, and this is called the late geographical hyperfluorescence. This shows the whole area of unhealthy RP and often seen in patients with PCV. So this, on the basis of PCV and ICG and FFA, you have two types of PCV. One is where you do not see a feeder vessel, you just see interconnecting channels. And here you see feeder vessel, which is called the BVN along with the polyps. So this is called the type A and this is the type B. The important is that it was first described by Tan et al. And they said that the type A could have a better outcome after treatment vis-a-vis the type B. So sometimes if you are able to look at this and make out this differentiation, you can prognosticate one will do better. Again, there have been two schools of thought that any type 1 CNV with polypoidal lesions could be PCV. So there is another term which has been coined for it, PCV or aneurysmal type 1 CNV. If you see the profile of the uvea, normally it is a U-shaped profile, which is that the thickest area of choroid is under the fovea. But here in cases of PCV, it shifts peripapillary. So nasal to fovea or peripapillary is where you see the largest area of thickened choroid. The central foveal thickness itself may not be that much, but as I said, it's the luminal enlargement along with thinning of the stroma is what is more typical. So these on OCT, these short and peaked PEDs are the ones which are very typical of PCV, and they are the ones which have the underlying polyp. And this is the two parts which we saw. This is DLS, as I said, very common, and you can see this is hyper reflective below the pigment epithelial detachment. This is also another kind of FIPED, and you will often see a BVN here. This peaked PED will definitely have a polyp below it, and you can see this is the corresponding octa. This is 6 by 6 millimeter scan of ORCC slab, which gives you a BVN, and you see this is a hyporeflective space, which is typical of polyp. And if you see a 3 millimeter by 3 millimeter scan, you can make it out very nicely. This large polyp here, which is sitting. So where the Octa is concerned, it is almost up to 100% successful in picking up BVN. And in fact, based on Octa, just like based on ICGA, we had type 1, type A and type B. Based on Octa, we have type 1, type 2, and type 3. And the trunk pattern of the type 1 is the one which is associated with more drusen, thinner choroids, and the outcomes may not be so good. And the glomeruli pattern of the type 2 is more associated with the thicker choroid, and here the recurrences are very high. The stick pattern or type 3 is in fact much better appreciated on OCTA as compared to ICGA, but here these are very small lesions where the hyperpermeability may not be seen on ICGA. So you can see the stick pattern is just like a small little bar of hyperfluorescence which is seen in the OCTA pictures. So various other authors have described based on the shape, based on OCTA, but important thing to remember is that where we saw that almost 100% of the BVN can be easily picked up on octa, on the polyps on octa not so easy to pick up, something like 50 to 60% or 70% of cases. And the reason is that the flow, if you remember, octa is all about flow. So it is able to detect the flow of the RBC and share and represent that as an image. So if the flow in that particular area is too slow or it is too fast, it is not going to be picked up by octa, which is why it starts the uptake or the show of polyps is less. Plus, it is only recently that we are having the swept source OCTA, which is able to have better penetration and into the choroid and able to image that area better. Most of the other OCTAs till now could not image the choroid so well, so which is why the detection rates of polyps have been poor as of now. And this is what the recent article in JAMA has also spoken about. They have used SSOCT and they have been able to pick up these polyps very nice. The previous picture that I showed you was also on SSOCTA where you could pick up the polyps, but this is really good because they pick it up as a bunch of tangled vessels and which when after anti-VEGF can really shrink, and you can see the response to treatment in these polyps as well. So the carrying home point is that the neovascular AMD vis-a-vis PCV, the differentiation is important because the recurrence rates, prognosis, the way the disease behaves is different in the both the entities. And we had a study from our center. We saw almost 30 to 40% of the cases were PCV whenever a serosanguinous kind of maculopathy was seen. So focal choroidal excavation has been described by a few authors, and they say that because of the bogginess of the choroid, there are areas of choroidal excavation which happen because of choroidal thinning which happens, and it may be something like what we call conforming, which means that the photoreceptor layer follows the area of excavation, or non-conforming, where the photoreceptor layer stays away from the area of excavation, and there is almost like a SRF kind of a gap between the two. It may be complicated by the formation of a CNVM, and here you can see a CNVM covering this area of focal choroidal excavation, and after treatment, this CNV disappears, and you have this fluid stays back. And the fluid, usually the CNVM associated with type 2, but type 1 has also been described. This is a very unique entity with peripapillary pachychoroid syndrome. Not many cases described. The importance is, if you see, it also has large choroidal vessels. It may be associated with choroidal folds, with a crowded disc, hyperopic refractive error, and almost no signs of inflammation. And you can see that here again, uh, the most peculiar feature is seen in this example that I'll show you. You see large choroidal vessels, the pachy vessels which are there, are all nasal to fovea. That is peripapillary and nasal to fovea. Hardly anything is present temporal to fovea. Here also you can see there is no stipple hyperfunction temporal to the fovea. If you see the OCT, this is the other eye ICG. Again, there is typical pachychoroid vessels, hyperpermeability, all nasal to the fovea. in between the disc and the fovea. And if you see OCT, this is remarkable. You can see temporal to fovea, the retina is very compact, and all the changes here are present in between the fovea and the disc. And you see the large choroid is also thickened here. And if you see nasal to the disc, also you will see area of thickened choroid.
No, alternate day.
That is the peripapillary pachychoroid. So
Rajan.
all these
Yes,
things
others,
together,
1 minute,
it's
Parveen.
not necessary that one thing
Parveen, just
you may
sorry
have
to interrupt. Sorry to interrupt, Parveen. You're doing well. We are able to hear you well. I want the other people to mute, please, because I'm able to hear some sound, extraneous sound there. Go ahead, Parveen. Thanks a lot.
Thank you, sir. So it's almost the end of the talk that we can see all of them together, but it's not necessary that one thing leads into the other. You may have PNV, which may directly go to PCV, or you may have CSC, as I said, which goes into PCV because of long-term irritation of the RPE. So overlapping features as well as progression from one form to the other is often seen. From the management consideration, I am only mentioning a couple of things because this was largely to show you the clinical spectrum of disease. There are conditions like PPE, FCE in the absence of CNV, and CSC with PED or PCV, which is asymptomatic. These diseases don't require any treatment. They need to be observed and monitored. But when you have cases like CSC with persistent fluid, PNV with macular exudation, and PCV, which is of course causing havoc and reducing the BCVA, we need to treat these cases. So it is important to differentiate between the two. Anti-VEGF therapy, otherwise, in the absence of a CNV, doesn't work well for CSC, but in presence of CNV, it is a treatment of choice. Intravitreal anti-VEGF can be used. All anti-VEGFs, including aflibercept or ranibizumab, can be used for CNV associated with FCE or CSC. So important carry-home points, it is important to distinguish it from AMD, important to distinguish the various categories of pachychoroid spectrum because treatment will differ, the management will differ, and multimodal imaging is necessary. That's all from me. Thank you.
You can stop sharing the screen, Parveen. It was,
Yes.
yeah. I think we should all put our hands together. If you're able to hear our hands clapping, I think it should be done for Parveen because it has been a fantastic presentation, incredible presentation. You covered the entire spectrum of the pachychoroid and you differentiating between the CSR, CNV, and also the IPCV, and also the neovascular component of the pachychoroid spectrum as well. And before we go on to Dr. Ajay Arora, Ajay, are you ready with your slides?
I think I will be able to share, but I think best is that if people have questions, we should first ask Praveen and clear up all the doubts which people have.
No, what we thought, Ajay, you can just present your experience.
This is a small case, which is very interesting.
Yeah.
So if you want just 4-5 slides, so if it is okay, I can do that now.
Yeah, you can do that. You can do that, and then we'll have a panel discussion.
Okay. So I'll start sharing the screen. I can't get my own photograph on. Hopefully the screen will show up.
Yeah.
Let's see. So can you see my screen?
Yes.
Okay, so let me just go back.
Yeah, I'm able to see your slides, Ajay.
Yeah. Okay. So this is
Can you just put slideshow?
And I would like Praveen also to comment about it. This was a 49 years old dentist who had come to me. This is his right eye, and this is his left eye, and he was having a CSR for more than 6 years now. He had been treated by various treatments, including epinephrine, and he was a chronic smoker. So this was his right eye. He had a pachychoroid, and we found there was a notched AD. So you can see here that he had multiple small PEDs in the left eye. And now if you look at carefully in the right eye, you can see that there is a choroidal thickness, there's a notched PED as well as, and there was a early double layer sign. But if we look at this particular thing, when we did an octa, the green thing reflects the choroidal vasculature. And we were able to demonstrate on this polyps which were coming below this, which we looked at on the deeper slab. We were able to find that uh, it was a neovascular CSC in the right eye. And in the right eye, we treated him with Eylea. This is his picture in February, and subsequently he responded very well. And in fact, he had been referred to me for micropulse laser. In the left eye, we treated him with micropulse. He had a bilateral chronic CSR. And this is initially after a month of micropulse treatment, his neurosensitive detachment had worsened, but eventually he settled down. So I just a take-home point that a patient with chronic CSR, it's a very important thing, as Praveen said, to rule out the presence of a neovascular CSR. And in case we find that, then the treatment actually is anti-VEGF rather than treating with a micropulse or a PDT. And that's what I thought was a take-home message I wanted to share with you.
Ajay,
Yeah.
I just want, why you did, instead of giving Eylea for the other eye, why you did MicroPulse?
So other eye had CSR, where
Chronic
there was
CSR.
chronic CSR, and
Yeah.
he had been treated by various modalities. So for that chronic CSR, we have been treating with micropulse, and we've had very good results. So in absence of any neovascular CSR, the treatment of choice is either PDT or micropulse. But if you have neovascularization, then we have to give an anti-VEGF.
Anti-VEGF. Okay. Uh, is that all, or shall we go to the panel discussion?
Yeah, I think so.
Yeah, Ajay, thanks a lot, Ajay, for the nice presentation. Once again, I'd like to thank Parveen for the wonderful presentation there. Now, let's go to the panelists. And I want the opinion from Dr. Manoj Khatri. Dr. Manoj Khatri, if you're
Yes,
online there, I just want to know what exactly is your take on Parveen's talk, number one, and what you would like to do to differentiate these different aspects of the Pachychoroid spectrum.
Ma'am, excellent talk. Well, you are master in multi-imaging. Whenever there is a topic of multimodal imaging, we cannot think of better than you. Totally agree with all the points what you have mentioned. A couple of doubts have been raised by the audience. Must be clear that they wanted to know some more detail on double layer sign. Okay, whenever it's a multi-layer PAD entity, throw some light on that.
So the double layer sign is different from a multi-layer PED. So double layer, what happens is usually the RPE is always in approximation to with the Brooks membrane. So RPE Brooks membrane complex, they appear as a single hyperreflective layer on OCT. But when you have a type 1 CNV developing, it develops between the RPE and the Brooks membrane, and then these two high reflective bands, they separate, and this gives rise to the double layer. So that one layer of RPE, other layer of Brooks membrane are now easily distinguished because of the presence of fibrovascular tissue in between the two. So this is double layer. Multi-layer PED is classically described when you have a long-standing PED and you have been long fibrovascular tissue. and then you have been treating it with anti-VEGF, so that the chronicity of treatment, some areas shrink, some areas alter and cause fibrosis, and some areas appear as high reflective, there are areas of low reflection. So that gives you a multi-layered appearance within a pigment fibrovascular pigment epithelial detachment. So that is a difference that's usually seen in cases of AMD, where a chronicity 17, 18 injections of anti-VEGF have been given. This is typically described for a pachychoroid, that you have a BVN growing in between the RPE and the Brooks membrane, and this gives rise to the double layer sign.
Thank you very much, Parveen, for the nice explanation of that. I want Supriya's opinion on this, and then we go on to Dr. Karthik.
Yes, ma'am. Excellent presentation. I don't think any of us need to re-emphasize that. We all know that you're the ma of multimodal imaging and all. A couple of things I just wanted to ask you is, when you have these PEDs and all, how do you go about it? Like, do you do a manual segmentation for all your images, or do you just go by the automated segmentation? Because even in Dr. Ajay Arora's patient, it was just an automated segmentation that I saw of the deep layer. So would you move the slab to where you are interested, and that may pick up the the lesion better, or how do you go about it?
Yeah, absolutely.
Because it is time.
That is absolutely spot on. So when you can do an automated segmentation most of the times, but in presence of a pigment epithelial detachment, you definitely have to do a manual segmentation, because otherwise all your interpretation will go haywire. So if you have not elevated your segmentation lines to follow the RPE, your interpretation will go wrong. So you are absolutely spot on. When in presence of PED, that is a major limitation of Octa, that in presence of sublingual cartilage, in presence of large PEDs, segmentation problems and shadowing makes Octa very difficult. You cannot get any information. Yes.
Can I say something here? Yes.
Yes, sir.
Ajay? Yeah.
Praveen, this is just a question. What I have observed we have the Zeiss Angioplex. In fact, if you have done the automated segmentation, and especially if you're looking for any polyps on an octa, your BVN you can make out, but polyps, sometimes one has to be very careful. If you move the mouse by 1 twirl, you can move by about 10 microns. So I found that by doing that, by moving a little up and down, you are able to get on the deeper slab. You sometimes can pick up, as I showed you in that, we could actually pick up the choroidal blood flow, and there was a small little break in the Brooks membrane where you could pick up that thing coming up under the PED. So you think you will do that, or because it's time consuming, but it really works well?
Yes, I agree with you. That definitely works well to move the segmentation lines a little below. Another thing which you can do actually is something called the volume rendering, or if you directly see a video of the whole octa. So it takes care of all segmentation issues. In that case, you will see the line moving down from the from the ILM down to the superficial fluxes, deep fluxes, everywhere, and you can see all layers. So we in trying to see the printout of octa, we are actually converting a 3-dimensional test into a 2-dimensional test, which is counterproductive. So you can actually see a volume rendering, you see a 3D video, and you see it going through the whole layers of the retina in an automated fashion, and from ILM down to the hallus layer it will take you, and you'll not miss anything. So if you are not very comfortable doing your own manual segmentations, you can convert the whole thing into a video. And
Okay. Is Karthik there online?
Yes, sir, I'm
Karthik,
here.
please.
Karthik, please,
Yes.
I want your opinion on this, Karthik.
Yeah, madam, excellent presentation, madam. I have just two doubts. One is on the focal excavation. How would you differentiate if that focal excavation is an empty cavity or is it filled with subretinal fluid?
Yes.
And the other question is there any gender bias towards a choroidal thickening? Basically, we see CSE present in the male population more than the other population. So would you suggest that there is going to be any gender bias towards taking an extra step to have an enhanced depth imaging done for all patients, or would you restrict them to only the male population? Will there be a gender bias towards the focal choroidal thickening in these patients?
So going to your first question. So normally, if you have a focal excavation and if there is no CNV, it should appear as hypofluorescent on ICG and FFA because there is loss of choriocapillaries. If you see it as hyperfluorescent, then you are definitely looking at a probable CNV. And if you have an octa, it will show you a network. So octa doesn't leave much to imagination, but if you don't have access to it and you do FFA ICG without a CNV, a FC is going to be hypofluorescent. With the CNV, it is going to be hyperfluorescent. So that is the important difference. Well, second question, gender differences are there, but if I have a patient, and I'll depend more on the clinical features rather than male female. So if I feel this clinical feature fits in the pachychoroid, I'm going to do that. So male preponderance is there, but I go more by the clinical features than just by gender.
Thank you, Madam.
Okay, I just wanted to ask a question, Parveen. Do you feel that Swepso's OCT makes a huge difference as far as the pachychoroid spectrum diagnosis and treatment is concerned? And how many of the panelists have access to Swepso's, and you feel that's better than the spectral domain? I want the opinion of all the panelists here.
Yeah. So if you are looking only at OCT, SD-OCT comes with the EDI, enhanced depth imaging. So
Yes.
that takes care of the choroidal imaging, is very nice. So that is not an issue there. Where the Swepso's OCTA is concerned, so there I think the Heidelberg OCTA, I am not familiar with it, we don't have it, but I think they are improving upon their choroidal imaging there also. But SD-OCT with EDI is as good as Swepso's OCT. So where the OCTs are concerned, the SD-OCT, the Heidelberg, the EDI is quite good. It shows you the whole of choroid. Some of my images are actually from SD.
Yeah. Parveen, you're using the Topcon Swepso's OCT in Shankar Netralia?
We are using angioplex leads from Zeiss.
Zeiss.
OCTA.
Okay, OCTA. Okay. How about Karthik? What are you using?
Sir, we have both the Zeiss machine and the Spectralis machine. We use them both. But in case if we need to see a specific BVN that we need to search for, I mean, if it is not appearing clearly well in the Spectralis machine, then we would go in for the Zeiss to get another scan done and then compare both. But what we've seen is preference would be for the Zeiss machine to get a better picture quality than the Spectralis machine.
What about Ajay?
So I have, we have the angioplex and no financial implications here. But what I found was that each one of us has to decide as to why you're buying an octa, because octa is not only for retina, but also you need an OCT for the anterior segment people. So if you're going to have one machine which is going to do both anterior and posterior segment, then maybe having an SSOCT is not a good idea, because SSOT somehow is not very good for the anterior segment. So when I had to make a choice between spectral, between SD-OCT versus Swepso's, we decided on an angioplex because, otherwise my wife is going to kill me. We had to make a decision, and as Praveen said, we have an EDI in that. Of course, you are not able to go right up to the sclera. The advantage of Swepso's is you can see in one shot the vitreous retina, the choroid, as well as up to the sclera, where which may not be possible in SD-OCT, but I think whatever treatable lesions are there at this point of time, SD-OCT gives us extremely good pictures. I am pretty happy with it. I had a few questions for Praveen though. Can I ask them now or you want to come back to it?
You can ask. You can ask. Before we
Praveen,
go on to the other questions from the chat,
yeah.
you
So
can,
Praveen,
you can ask your questions now.
It is very basic thing. You know, the whole spectrum of pachychoroid spectrum started with paper came out in 2013, where they had this pachychoroid pigment epitheliopathy, which was labeled as form cluster of CSR. Now, if a case of PP develops a neovascular membrane, the question which people normally ask is, how do you know it's a BVN versus a CNVN? You know, BVN, see, because basically both are networks. So if I label something and it's a case of, say, PPE, which develops a neovascularization,
So,
whether I
Dr.
should...
Ajay, you have asked a question which you know there is no answer to.
Okay,
So,
I thought
Dr.
you had
Ajay,
an
you
answer.
know there is no answer to this question. And so that's why I'm asking. But anyway, the Western population believes there is no PCV and BVN and type 1 are the same. The Asian population believes the BVN and type 1 are different. But then that is why to bring the two together is the term which I referred is being used AT1 or the aneurysmal type 1. So the type 1 means BVN, aneurysmal type 1 means PCV. So in the Western population, they believe any type 1 CNV over a period of time could go through polypoidal tissue and cause a PCV. So we believe that PCV as such is a different uh, entity because we see it more often and it behaves differently from a typical type 1. The differentiating point, I think, main thing is if you have a type 1 in the setting of a large, thick choroid, then you are more likely to look whether it's a polypoidal PCV or something like that. So that is the differentiating point. But if you see in the end, I quoted a study by Huang et al., who
Yes.
have actually divided PCV into type 1, type 2, and type 3, where the type 1 they say is like a more like a CNV and the choroid is thinner and we have drusen also, because all of us have seen this overlap that some amount of thin choroid, type 1's BVN is present, typical polyps may not be present, but choroid is thick, and drusen are also present in PCV. So this little overlap is there, but largely it is the thickened choroid which sets the two apart, and the kind of exudation and serosanguination recurrences that you see in PCV, you may not have that kind of a thing with a typical type 1 AMD lesion.
Parveen,
Thanks, Praveen. Actually, a lot of questions, but I'll ask Mohan Rajan to continue with the discussion.
no, Ajay, I don't know. I
Yeah.
just wanted to know from Parveen and Ajay as well as the other panelists, is the treatment going to be different ultimately?
Yeah, so because if you have a polyps sitting there, you're
Yeah.
at least where I'm concerned, my aim usually is that can I do PDT here?
Okay.
If I do PDT, at least the number of anti-VEGF injections
Can come
comes
down.
less. The treatment becomes more finite, and we know that maybe in presence of polyp is what makes a lot of these cases of AMD resistant to anti-VEGF. So first thing that they say is if a AMD patient is resistant to anti-VEGF, non-responsive to anti-VEGF, look for PCV. But we have seen so many of them that we directly start thinking that is this PCV that we are looking at.
What about Supriya and Manoj? Any opinions? Any takes on that?
Yeah. Supriya, you go ahead, please.
Yeah. No, sir. As ma'am says, I think it makes sense because we are always looking at where we can do PDT and reduce the number of injections. So that comes in the beginning itself, and we see a patient with hemorrhagic PEDs and exudates and a BVN on the OCTA. I had a question that I wanted to ask you, ma'am. The terminology that you use, that FIPID, and the other one, which is shallow irregular RP elevation. Are these the same things? Because that is with reference to non-exudative AMD, which later becomes, or is the choroid thickness a difference between these two terminologies? Like, because each paper has comes out with a new term, and then your
FIPID is typically to show little flat, irregular, almost like a DLS, but little height is more. So that is what they started calling it FIPID. PD is
okay.
usually
The shallow irregular
dome-shaped PEDs. This is not dome-shaped. This is flatter and surface is irregular. So
they call that shallow irregular RP
yes,
elevations.
the same thing is called flat or shallow thing.
But is the choroid thickness a difference between these two? No.
No, in a setting of thick choroid, usually the shallow and irregular PEDs happen in pachychoroid only. So that only is called FIPID.
Okay.
Manoj?
And do you look at the vascular overlay of your OCTA scans, like Dr. Ajay Arora showed in his patient? Do you look at the vascular overlay in all your OCTA scans?
The vascular overlay means the flow overlay over the B structure.
Yes, yes.
Yes, that gives you very important indication. Helps you differentiate between a type 1 and a type 2 CNV. In fact, polyp, if you have a doubt whether you are dealing with a small pigment epithelial detachment vis-a-vis a polyp, you look at the flow overlay onto the structural B scan. If there is flow there, then it's definitely, you'll think more of a polyp. And if you do not see too much of flow, then it could be just an elevated drusen or a small PED.
Yes.
Manoj, I want your opinion on this, Manoj. Manoj is there?
So
Manoj?
While Manoj is coming, with IDEA coming in, a number of PEDs have reduced a bit. No, do you think that, or
no, I
because we are doing
much,
much less PDTs as compared to before. So why do you think it's because of the presence?
True. So definitely, aflibercept definitely works better on polyps as well. So you would, if at all, if it is safer to do an anti-VEGF, you may get away with just an anti-VEGF injection. But recurrences are the thing. You may think of PDT, but the number of times you would do a PDT is becoming less because aflibercept is equally effective.
So Praveen, I have a question. In case you, again, the same thing back to BBN and CNVN, in case you think it's a BBN related to PCV or in a setting of, say, a neovascular CSR, in these cases, would you prefer, if you have to give an anti-VEGF, would you prefer an aflibercept versus any other agent, or you will not differentiate?
Yeah, so BVN definitely responds better to an anti-VEGF. And if I see it in the setting of a thickened choroid, aflibercept would be my first choice because we know that it works better. So you could consider aflibercept as your first choice once you see a pachychoroid spectrum.
So that's what I wanted to point out. This one point is PDT, when we have to differentiate between this and other,
PDT for polyps. If I do not see polyps, then yeah.
Yeah, Manoj is there on the line.
Yeah, sir, just want to introduce two other doctors who are there online and they have a lot of questions. Dr. Yogesh Patil from Bombay as well as Dr. Swapnesh Rawat from Bombay.
Has given a lot of questions there. You can read out the questions, Manoj.
I will request them to unmute themselves and ask the question directly. That will be better. Yogesh and Swapnesh, can you unmute yourself and please ask the questions?
Hello everyone. That was an excellent talk, PK ma'am, as usual, kind of. So my question was, many a time we see that pachychoroids or PEDs which are vascular and that trace SRF which are along the edges of the PED, you give n number of anti-VEGF, it doesn't resolve, kind of. And how do we proceed in such cases?
So pachychoroid itself should not have SRF.
Okay.
If it has got fluid, then you are dealing with something more than pachychoroid. Then you have to do a FFA or ICG to see what is causing the SRF. Is it only CSE or you do an octa to see is it only CSE, or is it vascular. So here again, if you see a type 1 CNV there, I would advise that multiple anti-VEGF injections are to be given. But if you, sometimes as I mentioned, that you may have a vascular CSC, but the fluid may still be there because of the choroidal hyperpermeability, in which case PDT to the area of choroidal hyperpermeability or a micropulse laser would probably help to resolve this SRF. Also, you could give an anti-VEGF in addition for the choroidal neovascular membrane. I hope that answers your question.
Yes, ma'am. Thank you.
Swapnesh.
Hello, good evening, everybody.
Hi, Swapnesh. How are you?
I'm good, sir. Regards to you and PK, ma'am, and Manoj and Supriya.
Thank you.
Ma'am, I had one question. Correct me if I'm wrong. The concept of RP splitting is there in SHRM, SHREM. Also, as we discussed, it is also present in other terms. So, are all these only OCT terms? Do they overlap? So, is there some clarity? How do we differentiate SHREM from only a FIPED, or because after some point of time, a FIPED may turn into a SHREM. Yeah, and do we do octa in all cases of SHREM to know its vascularity?
The SHREM actually is the term which is typically used to represent hyperreflective material, subretinal hyperreflective material, and it is largely above the RP. So more typically seen in a type 2 CNV along with hemorrhage and fibrosis. And because you cannot make out which is hemorrhage, which is fibrosis, you call it as a broad term called SHREM. So any fibrovascular PED can give rise to SHREM, or a type 2 CNV can give rise to SHREM. DLS is something which happens below the RP. So you see that below the RP. But if you have access to octa, octa will be able to differentiate between a vascularized SHREM as well as presence of a CNVM within the DLS. So that is the advantage of octa. It can differentiate the various structures in SHREM, which is hemorrhage, which is fibrosis. Classically, and above the RP, that you see hyperreflective substance in the subretinal space, that is SHREM.
And it's mostly a collection of some material there and happens over a period of time. So if you're following up a patient, SHREM happens over a period of time.
Yeah. So this
So that
usually
is
means
one of
it
the other
leads to a disciform scar, and then visual prognosis is bad.
Yeah,
So
very, yeah.
it is
So
SHREM,
the
the scar formation above the CNV.
Yes.
So, the previous question was also regarding the multi-layered PED which I had put up. Now, SHREM also happens in a chronic case, whereas multi-layered PED also occurs where you have given multiple injections. And sometimes it is really not possible, or unless we ourselves do the OCT. Most of us do not have a OCT. We send it across to a common center in Mumbai where it is done, and when we get it back. So is it really important treatment-wise to differentiate between SHREM and multi-layered PED? Is there any different prognosis in both cases?
Yeah, I would say SHREM means it's an actively exuding membrane. And multi-layering is usually a sign of chronicity, that the neovascular complex is kind of shrinking and dying, and just a skeletal framework is remaining. So you need to differentiate the two. SHREM above the RP exudation gives rise to SHREM, and when you have this the skeletal framework of the veins and the neovascular complex is really shrunk, it gives rise to that multi-layered PED. So this
Both are poor prognosis.
Yeah, both. But one is the active stage, an aggressive form, you'll have SHREM, and the chronicity will give you the multi-layered PED.
extension of the same question, as we are worried about retinal atrophy in any type of a CNVM or a PCV, are you worried about continuous treatment with a patient going for a choroidal atrophy in these patients, especially with pachychoroid spectrum?
More than pachychoroid, I think when you have this multi-layered PED, these were the cases initially when we tried to flatten all the fibrovascular PDs with giving multiple injections. So that is the setting which causes choroidal atrophy, especially in presence of thin choroid. In pachychoroid spectrum also it has been seen. That is why I said that I recently read an article which was geographic atrophy because of pachychoroid. So any of these things, once you have a neovascular complex forming, and if you treat it with anti-VEGF and then atrophy happens, so atrophy can happen in presence of a thickened choroid also. So that
Yes.
will be pachychoroid geographical atrophy, is what
Yes.
is my understanding. But largely, no more, I think a lot of us do not try to flatten out fibrovascular PEDs anymore, because that is the main culprit in causing macular atrophy in cases of repeating anti-VEGFs.
Repeated anti-VEGFs can cause
A
atrophy.
little bit of fluid which is left there is considered that this fluid may have a little bit of nutritional value. So you don't want to get the complete fluid off.
I just want to ask a basic question to all the panelists and the speaker. You know, CSCR is a very common problem, especially and faced by all, even the general ophthalmologists. I just want to know what is the protocol, the first line of management for an acute CSR, and the first line, second line, and the third line, and also for the chronic CSR. In your setup, what do you do?
So for an acute first episode, I think they're usually typically, young men who are a little type A personality, as we call it. They usually come with a little fluid and the posterior pole vision is 6.9 or even 6.6. First visit, I may not even advise an FFA. If at all, you can do an OCT to document how much is the fluid now, so that when you call them a month, 2 months down the line, you can compare by repeating the OCT, a non-invasive procedure, to see whether it is resolving on its own. It will very clearly show you whether the fluid has gone down or it is increased or what. So as long as the fluid is absorbing well, it's a first episode. You may not even need an FFA to see where is the leak and why is it leaking. Just lifestyle changes, and if any history of steroid intake is there, you can just change that.
Do you give any medication like epineuron?
No, not at all. Epineuron is anyway usually given more for chronic CSE, not for the acute episode of CSE, not required. Nothing is required.
Okay, what about the opinion from other panelists?
So same, I think I agree with what Praveen is saying. Acute CSR, we normally say up to 6 weeks. We don't treat them at all. We just reassure them. We would definitely ask them to make a lifestyle change if they can, in case we find that, as Praveen said, they're type A personalities, and usually they respond. It's only after 6 weeks that the dilemma starts, between 6 weeks and 6 months. If the patient at 6 weeks is improving, we would still like to wait for a little longer time. But if the patient is not improving, and if the patient is demanding treatment, then we can consider at that time what is the various options that are available.
Will you do an FFA in the
So in the first 6 weeks, I don't think an FFA is required, because CSR can be diagnosed clinically without any problems. And you really don't need an FFA, because FFA is going to show you a leak. You're not anyway going to treat this patient. And so it really doesn't, I don't do an FFA anymore in these patients. If at all I have to do, and it is required, we might do an OCT just to show the patient that eventually the patient is improving, so that patient can, feel reassured that patient has improved over a period of time, and that is good for the patient.
What do you do, Karthik?
Sir, same as what the professors told, sir. We do the same, ditto. No change.
No change. Okay. You do you give any anxiolytics?
No, sir. For some people who are type A personality that we know who have a night shift and a day shift problem working, for them, maybe we would consider giving them a sedative, mild sedative during their sleep hours, if the sleep hours is going to be in the daytime. But other than that, we don't give an anxiolytic, sir.
Okay. What about Manoj and Supriya?
So I think the same as Madam and Sir had said. We would just add on an OCTA just to see. I mean, it's good to have a baseline and then follow them up to look at the choriocapillary layer. But treatment-wise, the same. We would just observe.
Is there any indication for laser in these patients? Suppose patients got recurrent CSR.
So recurrent CSR means now we are looking beyond 6 weeks or.
Yes. Yes.
So that time, if the fluid is not resolving or it is coming back again, now is the time to do a fluorescein angiogram to see where is the leak. And if it is extrafoveal, safely a thermal laser can be done. So there is a role of laser to, it reduces the number of recurrences that patient may have.
Okay, the problem, I think the bigger problem is the chronic CSR all of us are facing now. So what exactly is the treatment protocol you would advise for that? The first line, second line, and third line.
So chronic CSC needs to be investigated.
Yes.
So FFA, ICG, and OCT, all three need to be done. And once we do that, most of the time you find it is just a multifocal leak, and you can still do thermal laser and at least seal off the major common leaks which are present. And then if you still feel that that usually takes care of a lot of fluid which is present. If not, then I think my next option is to do PDT.
PDT.
And rule out presence of CNV, which I think is a question that incidence of CNV in chronic CSC, almost 10 to 15% of cases may have. So once you rule out that there is no CNV, then identify areas of choroidal hyperpermeability, and you could do PDT there in case you don't see any focal leaks. Sometimes a combination of thermal laser to the focal areas and PDT to the choroidal hyperpermeability areas may also be necessary.
Do you combine that with the anti-VEGFs as well?
Only if there is a CNV, I plan an anti-VEGF for chronic CSC. Otherwise, usually not.
Manoj?
And you will prefer a low fluence PDT, madam, or a full fluence PDT?
Actually, there have been various studies to compare the half dose and the low fluence and all that, and they have found that both are equally effective. So if the low fluence is going to be as effective as the full fluence, then why not do low fluence and do the safety margin? But there are two schools that there's some, I think from the Japanese group, they definitely want to do the full fluence, because you actually want to take advantage of the side effect of PDT, that it causes the RP scarring, and you want to form a scar there so that the recurrences don't happen. So you could do in these situations of full fluence also. Usually no harm done. We don't do it for PCVs because there's a question of secondary increase in VEGF and all that. But simple chronic CSC, you have a choice. You could do either of them.
We do any fluence in our place. Supriya, you would like to have add anything for this?
Sir, I just have one question.
Yeah, Karthik.
Madam, you have any experience for using your yellow laser 577 nanometers?
I think in presence of Dr. Ajay, this question needs to go to him. Please, Dr. Ajay.
So, Dr. Mohan Rajan, I have a slightly different thing, because there are only 2 PDT machines available in India which are mobile. So getting this PDT is very difficult unless and until your institution has a PDT machine. So we have a 577 yellow laser. We use the micropulse, and for chronic CSR, we have used quite successfully in our cases. So if I don't find any neovascular, it's not a neovascular CSR, then I would go ahead and use a micropulse laser. There's a very good study from Korea right now, which has been published in Eye, which they have shown that many times that you have to use in these cases multiple settings of micropulse laser at a much lower dosage, and they have given it on a monthly basis, and they have had almost 100% success over a period of follow-up of 27 months. So we have been doing not on a monthly basis, but the repeat treatment is done at about 3 months, and the success rate is pretty good.
And following on the same question, is no financial interest, but are everybody getting their Visudines for PDT?
Yeah, we are getting it regularly.
We are getting it. Yeah. We also do low fluence only. And Supriya, you would like to have any other opinion on this?
No, sir. I think
There is a
we use
question on
the
micro.
yellow laser. We use the yellow laser as a poor man's PDT. I think not every patient can afford the high charges of a PDT. So in a lot of patients, even if it's subfoveal, we've used yellow laser, and in fact, we have published a paper of yellow laser usage in CSR in the eye also some time ago. So, and even I think in Arvind, you have Dr. George and Dr. Anand doing a lot of yellow laser. So it definitely works, and I would even call it a poor man's PDT actually.
Supriya, why are you calling poor man's? You should not put your shoulders down and call it poor man. I'm sorry, that's not the correct term. It works as effectively, and I don't think you should call it poor man's.
Ajay,
Yeah.
for your information, Supriya is the richest ophthalmologist in Chennai.
No. So I'm not commenting about her richness, but
That's why I work at Rajan, I think. With the richest boss.
Yeah.
Sir, there is a continuation question on what duty cycle.
Right.
Manoj,
There
question
is
is
a question from Micropulse. What duty cycle you use? Ajay sir, there's a question for you.
For Micropulse, we have a 5%. And what I do is I do a little differently. We do a test burn nasal to the disc. And once we do the test burn, from that we come down to a level of a 30%, 25 to 30%. So depending upon the chronicity, it's either the 25% power or the 30% power of the test burn. We are at a 5% duty cycle.
5% duty.
And usually we give a 200 micron spot for 200 milliseconds, and it works pretty effectively.
Very nice.
Okay, just a continuation on that. If you have any patient for PDT, kindly refer it to Chennai, sir.
Yes.
Sure. You will have to pay for the flight, and he'll pay for the PDT.
Swapnesh, how is the cyclone in Mumbai?
Cyclone just bypass Mumbai, sir. Just
Bypass
bypass.
Mumbai. Okay.
Yeah. We just heard it's really fortunate. Yeah.
Good news.
Oh, I just saw some tree being uprooted in Belapur or something, no?
Yeah, so central Mumbai, core Mumbai, it has not affected. Navi Mumbai, Pune, Palghar, all that area has got affected.
Okay.
What about the other C? COVID, how is it in Mumbai?
COVID is actually not so bad because 42,000 people are affected, but 20,000 are already discharged. So actual active cases is half of that.
Now you're going to get herd immunity fastest in the country.
No,
Yeah,
Chennai also is the highest.
You will reach
Okay.
the peak and finish it off quickly. We
Yes.
will all be
Yeah.
lagging behind.
Anyway, what's the question, Swapnesh?
Sir, in continuation what Supriya told, so I was attached to a charitable hospital where along with Dr. Anand Subramaniam, who is also a SN alumni, we had treated 11 patients of chronic CSR with rifampicin. The dose of rifampicin, 300 milligrams, the split BD dose. And we had followed those patients up for 6 months. Out of 11 patients, we monitored the LFT levels every 6 weeks. And out of those patients, about 7 patients did well only with rifampicin. And during the time when rifampicin was given, we never intervened either by doing a laser or by giving a Avastin. Obviously, at that time, this is 3 years back, Octa was not available, but we had good results with that. And I believe that charitable place still continues this protocol of treating patients of chronic CSR with rifampicin.
But what about multi-drug resistant TB? Isn't that a concern for these patients? Like if you treat them for 6 months,
Yeah. So we
they
had
actually get TB. And then...
so that was an issue which came up in the later part of the study. So last 6 patients, we actually had a chest physician on board who would assess the patient immediately after we checked them 6 weeks later. But yeah, we missed the same concept in the initial group of patients.
Okay, good.
How long you give the rifampicin, Subnish?
So it was variable. We use the OCT to monitor the resolution of SRF. So it was in the range of 3 months to 9 months in all those 11 patients.
What
So
is
some
the
of the,
mechanism of action of rifampicin?
so cytochrome P40 is altered, and that is believed to have some effect on reabsorption of the subretinal fluid.
Very nice. Anyway,
But it is not a very consistent result that we got.
anything else you would like to add? Any other panelists, speakers?
I'd like to ask Praveen one basic question is that when you say pachychoroid, there are patients who have actually choroidal thickness. Supposing it's a focal pachychoroid, which is not subfoveal. So in those cases, this is just for the house for people who are tagged on. As to on this, do you have a definition which says this is pachychoroid when the subfoveal choroidal thickness is within the normal range?
So if you are looking at subfoveal choroidal thickness, SFCT, so usually if you're looking at quantitative, 300 to 400. Anything beyond 390, 350 micron is thickened. But as I mentioned in the initial few of my slides, most important parameter is to look at, the
Haller's layer.
the actual morphology of choroid. So if you have a 300 micron, but you have such a thickened hallus layer that the choriocapillaries and sacral is totally obliterated, and you're already having disease in the retina, outer nerve, nuclear layer thinning and all that, it will fall in the pachychoroid spectrum, even if the complete thickness of choroid is less than 300.
Right.
So it is the morphology. It's the
I just did this
thickening
to
of
be
the outer layer at the cost of the inner layers.
right.
So if you have that morphology, and which is why that CVI, has been used to qualify these things. So you could have the luminal area and the stromal area. So if the luminal area of choroid is increased at the cost of the stromal area, then you are dealing with a pachychoroid.
And if you have this uncomplicated pachychoroid cases, do you follow them closely?
Nothing to be done.
Do you follow them closely?
Yeah, in fact, you can't even follow them up because they may be having this issue just like any other patient. You will advise a regular 6 monthly to 1 year checkup. That's all maybe which is required, or maybe you could give them a home Amsler. But other than that, most often than not, it's an incidental finding. You do it for some other reason and you realize that choroid is thickened here.
Thanks.
Madam, one
Any
question.
questions from the audience?
No, sir. Done. We are done with all the questions.
We're done on all the questions. Any
Madam,
other?
one last question.
Yeah, Karthik.
Madam, since Pachy was for the last 10 years or so, pachychoroid has come up. Will there in the future be a term opposite for Pachy? So Pachy is thick. Will there be something?
Already a term opposite of Pachy. It's called the leptochoroid.
Okay.
So that is the extremely thin choroid. That is also seen. So that's called the leptochoroid.
And also that is one of the major concerns of treatment of patients having pachychoroid. That's the reason I asked this question. Choroidal atrophy is one of the major concerns. So we have to keep that in mind whenever you are addressing any kind of treatment for these patients.
Repeated injections can cause.
Yes.
Can cause leptochoroid.
Yeah.
Yeah.
From Pachy to become lepto.
Pachy to lepto. Yes.
That is the take-home message then. Okay. Anyway, we'll come to the end of this wonderful webinar. I would like to thank Dr. Praveen Sen again for the wonderful talk, really exhaustive talk, very comprehensive talk, and all the panelists who have done, I think, a wonderful job to, it's a very difficult topic, the pachychoroid spectrum, because it's a very, very confusing whole lot of confusion. And I think you have cleared each and every doubt here, and people are going home with a very, very clear take-home message. Stay safe, stay healthy. We'll meet again next week.
Thank you, sir.
Thank you so much. Thank you.
Bye. Bye from
Thank
me.
you.
Bye.
Bye.
Thanks, Manoj. Thanks, Supriya.
Thank you so much, sir. Thank you for coming.
Bye.
Bye, sir. Stay safe.
Hi. So are you online?